So I've been able to travel to hospitals in Indonesia, in Malawi, in the Philippines. And so I've been able to see what healthcare looks like all over the world. And some things that we do in the US don't make any sense in other places. Sometimes it seems very wasteful. And I enjoy getting that perspective. I always come back refreshed and energized to take care of my sometimes needy patients in the United States. So, take the next slide. So today we were going to just talk about some general background information. And then a lot of the things that I'm going to reference were brought up by the American College of Emergency Physicians. And that's a large group in the United States that helps us come up with guidelines and gives recommendations for emergency medicine all over the country and often all over the world. They have an international branch as well. And then we're going to talk about different types of emergency department protocols and how these can ultimately improve our patient care. So I had to do a lot of research for this. I didn't know much about emergency medicine in Costa Rica. When we were traveling to Costa Rica, my husband had to do a lot of research to plan our trip. He loves to plan trips. He's my tour guide and and so he did a lot of research. We landed a week ago. We spent 4 days on the Pacific coast at the Planet Hollywood Resort, which is not real Costa Rica, but my children loved it. I have 3 children. The oldest is a daughter, Hannah. And then I have 2 boys, Rory and Jacob, and they are 10, 9, and 8 years old. So very cool. I also brought along my aunt who loves to travel and doesn't mind the children. So she helps us with the children. From Planet Hollywood, then we went down to the RNL Observatory. We spent 2 days in the beautiful RNL rainforest. We really wanted to see also Magiro, but we didn't see. That was our whole goal with this trip. But the children are going to the zoo today, so they will hopefully get to see one at the zoo. So when I was researching my part about what medicine is like in Costa Rica, even in the US, emergency medicine is a new specialty. It has only been around for the past 40 years. It used to be the job that nobody wanted, right? Same with ambulances. That's the job nobody wanted. It was whoever had a hearse. Do you know hearse? For dead people? What do you say hearse in Spanish? Yeah, it's the car that takes a dead body places. Those were the first ambulances. It was a job nobody wanted. And we've really come to take this as a specialty and to grow it and make it more of a well-respected specialty in medicine. And get out of there. The rest of the year, it's a beautiful place to live. There's So 80% of our transports are from smaller hospitals to our center.
During COVID, we had a problem. For the first time ever, we got too many transports. We were too busy. And so sometimes the smaller hospitals had to keep the people who didn't need emergency surgery or other interventions. And so that's been kind of a challenge that Sanford Health has had to work through over the last 3 years while we navigate that. But we rely heavily on the flight team to do that. To give you an example, Costa Rica is 51,000 square kilometers. That sound about right? South Dakota by itself is almost 200,000 square kilometers. So that's the difference there. And that's why a lot of our flights are 2-hour transports. Plus you have to use an ambulance to go to and from the airport. A lot of times we can't fly because of weather. For helicopter, so we have 2 planes, and then those planes can fly in some worse weather. We do have some ground ambulances, but during winter our roads are very slippery and it's not easy to go by ground. I'll take the next slide then. Oh, sorry. There we go. All right, so a little bit about our hospital. This is a picture, an aerial picture. The main campus is right here, and this is my emergency department right there. The whole hospital has 400 adult beds, and we have every subspecialty, neurosurgery, hematology, oncology, obviously obstetrics. We really don't need to transfer out very many patients. The only thing we will transfer out is the severe burns. Those will go to a burn center. And in the US, that's very common. Most hospitals, even bigger hospitals, don't manage burns. It's a specialty center. We also don't do like pediatric heart surgery. So the newborn congenital heart, we don't do those surgeries, but we do have specialists to take care of the children after their surgery there. All right. Next one. All right, so this is our children's hospital, which looks like it belongs in Disneyland. It's gorgeous. This was built in 2010. I understand you're going to meet Mr. Sanford in a couple next week. So he loves children and wanted to provide a place for children to come. If you think back to my map, there is a children's hospital in Minnesota. There is no children's hospital for 5 states. None. The one in Sioux Falls. So this was built in 2010. It has 58 NICU beds, it has 12 ICU beds. However, if during our recent flu season, we needed to move, we had more beds. They had to move to a different floor. And then otherwise we have 7 regular pediatric beds. When one of my children was newborns is this one. 58 is newborns. The 74 is otherwise, other than that. I had a son have a bone infection when he was a toddler, and he was able to have his surgery, his IV antibiotics, all of his rehab care right there in town, which is unique. So especially for children, we're again a major referral center. Our flight team, we do have a specialized pediatric nurse that will fly for children. And then all of our medics are trained to fly NICU, maternal, pediatrics, and adult. So the medics have to be very adaptable, So let's talk about my emergency department. They redid the emergency department also in 2010, and they increased us to 32 beds in our emergency department. In those 32 beds, we see 46,000 patient visits per year, and that has gone up by about 10,000 visits per year in the last 5 years. It's been growing. Our city is growing, our region is growing, and a lot of times when those transfers come from other places, they stop in the emergency department for stabilization or for imaging, CAT scans, MRIs, or for some procedures. So our emergency department sees a lot of those transfers. About 8,000 of those patients are children per year, and just in September, we started a pediatric emergency medicine department. We have 1 physician now, and in July we have 2 more coming. We hope to have 4 total, which means every day for about 8 to 16 hours, we will have a dedicated pediatric emergency medicine specialist. So that is something our region really needs, and I think will be well appreciated. We're currently a level 2 trauma center. I don't know if you're familiar with how the US ranks trauma centers. Level 1 is the highest level, and in May, we hope to become a level 1. So we're a growing center. We are a certified stroke center and a certified chest pain center. We admit about 30% of our patients, and from what Edgar told me, this is very different from here. Yes, we have a much higher admission rate there. Our average stay in our emergency department is almost 5 hours, which gets people frustrated. They don't like to wait. I don't like it when they're there very long. I always say I'm allergic to patients if they're there longer than 2 hours. I don't like it. So that's kind of where we're talking about how can we make these things go faster. So like I said, we're seeing more patients per year. They have longer wait times. They're sicker than they were before. All of these regulatory bodies give us all of these metrics we need to hit, faster times, get your EKG, medicine in this amount of time. And we're left thinking, what are we supposed to do? How can we improve things? So we looked at where patients start, and they start at, it's coming? Okay. They start at reception, and that is where we started to look at how can we improve things. Our reception is staffed with a nurse and then 2 registration people who help check in patients, or if there's an emergency, can call to get a physician out there, and so forth. And we asked ourselves, what if the care, is there a delay? There we go. What if the care could start outside of these doors instead of waiting until the patient comes into our emergency department? So we've developed a number of what we call nurse-driven protocols. A protocol that a nurse could place, but as we'll talk about, it has been agreed upon by physicians and it has been supported by evidence and by the American College of Emergency Physicians as a way to improve patient care and create better patient outcomes and expectations. Do you use an electronic medical record here? Yes? Okay. Does it have orders? No, not like...
Orders, not orders.
Or no order sets, okay. So we can kind of talk about that. A lot of these are order sets. In order to start doing protocols, we did have to create an area of triage where we could have a patient be able to lie down to get an EKG, to be able to get accurate weights for children and our patients. Our patients, I think, in the United States are bigger than your patients here. Some of them are quite big, yeah. We have a nurse in this area. A lot of times of the day, we have 2 nurses, one up at the front desk and then one back here doing the actual orders. And they can draw blood, they could place an IV, they could say this one is sick and needs to come back immediately, or we can get our labs and then the patient goes out to the waiting room. But we had to create an area that this would work. We hope to do another emergency department renovation in 2024, maybe, hopefully, because as we talked about, my 32 beds is not quite enough. Sometimes I do see people in hallway beds with 3 hallway beds. We probably need closer to 50 emergency department beds, and we'd love to have a specialized pediatric area. So that's our goal, our wish. Another view of our reception. So ASAP, I mentioned that, American College of Emergency Physicians, and they represent emergency medicine both at the government level as well as coming up with guidelines and supporting evidence. They want to advance emergency care by continuing education, research, as well as educating the public, and as I mentioned before, political activities. So we have a large ASAP group in Washington, D.C. There are other emergency groups, AAEM is one, and other smaller ones. ASAP is the largest, though. and they're probably the most well-known internationally. So they came out with a statement about emergency department protocols first in 2015 and then revised in 2021. And they said that these should be based on the best available evidence. They should provide a standardized way of treating patients with a common complaint, and that they're supported by evidence with ongoing education.
Doctor?
Yeah.
There are two questions.
Yeah.
By Dr. Viernik, our hospital director.
Oh yeah, I met him
Yeah.
last year.
He says, what percentage of
Ale,
the
perdón,
patients
sorry.
have insurance and how many
Sorry.
are not insured?
In South Dakota, it's a very high percentage that has insurance. It's probably, so in the United States, we have a population of Native Americans, and in South Dakota, we have 10 Native American reservations, so they have their own insurance, Indian Health Services, and that makes up about probably 10% of my patients there. And then private insurance is very popular, and then we have Medicare and Medicaid. I'd say it's probably 80% or more with insurance.
Okay.
Very high amount.
Okay. And then,
In South Dakota, that is unique for the United States. It's better in South Dakota.
and then what is the average cost per stay?
In a just emergency department,
Yeah. More or less an average.
at least $1,500 US.
Okay.
1,500, 2,000
Each visit.
each visit.
I mean, he working.
Yeah, I mean, the visits are about 5 hours long. So, for instance, Tylenol, a dose of Tylenol for a child, $75.
Wow.
If you come to my ER and I give your child Tylenol, that's what it comes to.
You have to take back time.
Well, I actually write a prescription for Tylenol. I do, for adults and children, because I'm like, take it, your fever will go away, you'll feel better. Do you have that issue where we were kind of talking that the non-urgent complaints, that's what clogs up the emergency department. And we'll talk about this with the protocols. The people that we can make the most impact on are the people with the medium acuity levels, right? So if you're sick or coding, you get back right away. We take care of you very quickly. It's not hard, it doesn't take long, that's easy. If you have a toe pain and you really don't need to be there, I don't really care if you wait necessarily, right?
Yeah.
It's these patients in the middle. So not every chest pain is a heart attack. These stomach pain, abdominal pain, that takes a while to work up. And that's where we'll see most of our ED protocols focus on that medium acuity level. Any other questions?
No, not for now.
So when we use standardized protocols, that doesn't mean that we put them in there and the nurse just clicks boxes on everybody and we never look at it again. This all comes with a recommendation to review the protocols and make sure that everybody's being educated. I don't know if with nurses it's the same here, but my nurses are getting younger and they don't stay in the same field. They move around. Is that the same here? Or is it just me getting older? But our nurses will come, and again, during COVID, they could travel and make a lot of money traveling. And so we lost a lot of nurses. And just like with physicians specializing in emergency medicine, it is a hard job to do. And to be an emergency medicine nurse and know sick or not sick, or I've seen this before, this needs a doctor right away. And so when we do these protocols, we always have ongoing training for the nurses over and over. So a couple of the benefits that have been found, and we'll show some proof of that later, is that we can decrease our length of stay. We can provide consistent treatment. I know myself, when I'm seeing the fourth abdominal pain of the day, I may very well forget to order the urine sample. And sure enough, then I miss, a urinary tract infection. So we want to provide consistent care. It can improve patient satisfaction. Because if the patient leaves the waiting room and comes back and gets their labs, and by the time they come to see me, I know all their labs and I either know what they have or what they don't have, it makes their actual care much more speedy. And it improves the relationships with colleagues, and we'll talk about that in a little bit. So these have there was another study or another point that ACEP put out is that these have the potential to reduce the variation in care, enhance your workflow, and modify your practice through evidence-based practice. A couple of the other things that ACEP said about emergency department protocols was that these can be a multidisciplinary collaboration. So you can have physicians, nurses, maybe pharmacy, radiology departments, or even administration all come together. Maybe administration knows what a lot of the complaints are about, or maybe the stroke team needs to improve how we recognize stroke care. Maybe they come to us and say, we want to do a protocol like this. And so it's everybody working together. And these, there's a couple of recommendations I think that are very specific for the United States, especially with patient-doctor relationship. So use of a protocol doesn't necessarily make a patient-doctor relationship, but if the orders are ordered through a protocol, ACEP recommends that insurance does treat those as something ordered by a physician and should compensate for those orders.
Doctor, I would like to emphasize, if I only get right there,
Yeah.
on the bedside manners.
Mm-hmm.
Because emergency is, I think emergency room has a small time to get to know somebody.
Yep.
And there are several books written on bedside manners
Yes.
and things. It's part of some of the curriculum in some medical school. For example, there are 7 C's. The first C for a doctor is competence.
Yep.
But that doesn't mean you're a good doctor.
Yeah, nobody likes you.
Communication,
Yes.
character,
Mhm.
comedy, everything.
Right.
Okay.
Yeah.
This another.
And it is a tricky thing to do because even what I think is important for the patient, faster, right? I want them to go through faster. I think that's great for the patients, but they don't maybe take that as good. They may take that as, she thought I was silly for coming in. She thought I wasn't really sick. Now, what do we have? Patients can only see this much, right? I have this is all I have. I can't show any facial expression. And so I've had to actually look at myself, really small. I've had to look at myself and say, you know, even things like giving your child Tylenol before you come to the emergency department, I've had to really take a look at myself and say, they're just scared. It's hard to be a parent. It's hard to have a sick kid. They don't know what to do, and I can help them figure that out, even if it's not cool emergency medicine, right? It's not, you know, my specialty of, you know, taking care of traumas or heart attacks or anything like that. But you're right. And while protocols can't make you a better bedside manner, it can help a little bit with knowing, okay, if they were worried they were having a heart attack, I already know they're not having a heart attack. I can tell them that right up front, and we can talk about that. So I want to stress that protocols are written and agreed upon by physicians. Our whole group has to come together, and they can be very empowering to nurses. In those pictures I showed of our reception, there's nurses sitting out there. That's who all the angry people waiting come to talk to. Why am I not going back yet? My grandma's really sick. Why are you not taking us back? They have to face all of that. And when they have a protocol that can say, you know, yes, we need you to wait, but I'd like to get these things started. The doctor would like to have these labs back. Then they have an ability to care for the patient. We'll talk about different kinds of protocols, but one of those can be medications. So if somebody is vomiting in the waiting room, they can have a protocol for maybe giving ondansetron. Do you have that medicine here? Nausea medicine. What they don't do is they don't replace physicians. When we started using these, I use protocols in training because I worked at a bigger emergency department. And so they have been around for a number of years. But when we introduced them, a couple of my colleagues didn't like the idea at all. They thought it was not practicing true medicine, that they were, it was cookbook, they say cookbook medicine. And that can be true to a point. And we are very particular about who these protocols get enacted on. For instance, our chest pain protocol is only patients aged 30 and up. right? We don't do an automatic chest pain workup on anybody. Our heart doctors want us to be everybody. But, and in the US, we do have early type 2 diabetes, so it's not impossible that that will change, but we do try to be judicious about that. It's not a nurse practicing outside of their scope. These are orders that the doctor has already pre-agreed upon, and so these are something that a nurse can enact without having to worry about being outside of their scope. We don't have 1,000 different tests on these protocols. We have a couple tests that every single patient with abdominal pain needs to have. Every single patient with chest pain will get a troponin, basic labs, and an EKG. That's it. So it's not wasting resources. You're not ordering obscure tests or very expensive tests. Most of these do not have even CAT scans on them, right? Or expensive studies. And we try to be very mindful as we put these together. For what, and you know, the nice thing with different facilities is you can have different protocols. So my center, right, that's a major receiving center and sees a lot of stroke, a lot of heart attacks, a lot of sick patients. I have different protocols than the smaller hospitals do, and they can be very customized. There's been a couple of studies looking at these. This one was in Spanish, it was from Brazil, so I was like, all right, I'll use this one. But basically what they were able to find was that it did increase the throughput of the emergency department, and again, especially in those patients in that middle category of acuity. So not the very sick and not the very well that were there, kind of that middle one. And I will have references listed at the end. Their conclusion there was that having these protocols in place from triage can reduce that length of stay, and they don't have any adverse effects. And that was a meta-analysis of 10 different articles looking at this. Many of the articles have been done actually by nursing associations around the world, because they're the ones, again, that have to face the brunt of the dissatisfied patients. I can say I need to go to a different room and then I leave. I don't have to deal with it. But the nurses are at the bedside more.
One question.
Yeah.
How long does it normally take to get a protocol passed? Assuming it is not a quick process. Who writes them and who approves them?
Mm-hmm. So at our hospital, we just did this last year. We looked at all of the protocols. We also looked at how many times they had been used. If they had not been used in the last year, we got rid of it. Nobody's using that one. There was one of my partners had adjusted them kind of to his liking, and he had put in maybe a couple orders that I don't ever use, and that most of our group didn't use. So we got a group of us, I think 5 physicians, that came together and looked at all of the protocols and said, okay, all 5 of us can agree. We order these 4 tests for every belly pain. We order this for every chest pain. So we put them together, and then Sanford has a approval process where a lot of the heads of departments have a meeting reviewing protocols. This is how I do my protocols for air transport as well. I write the protocol, and then it goes for approval. And different specialties will look at it. So cardiology will be more focused on my chest pain protocol. Stroke will be, or neurology will be focused on my stroke protocol. And you get input from there. And then once it's approved at that governing board, then it gets utilized and we educate the nurses. Okay, this is when we order this age of patients. For instance, we have almost no pediatric protocols, very few. Just because with kids, it's so hard to tell, right? And they're less likely to have a heart attack and that kind of stuff. So we have very few, but for adults, then they enable those. Does that answer the question? Okay. There's different types of protocols too. So some of those can just be based on the chief complaint of the patient. So chest pain, abdominal pain, so forth. Some can be medication driven to give nausea medicine if somebody is vomiting. If the child has a fever, when they check in the triage area, to give them Tylenol or ibuprofen. And within the protocol, it says the nurse has to ask the parents if the child has had that medicine already, okay? We have some radiology protocols. If somebody comes in and their arm is abnormally shaped, We can get an x-ray. You know, we know we're gonna get an x-ray. You're not gonna not get an x-ray, so we might as well get it going there. Or ankle pain, I can get an x-ray and I can know before I even see the patient if they have a fracture or if it's a sprain, and know right away how I'm gonna handle them. A couple of our other protocols that aren't implemented in the triage area are our trauma and our stroke protocols. So those are enacted in our trauma room. The nurse has an order set, and it's based on age of the patient, gender. So for females, we need a pregnancy test. We have emergency release blood on there. We have all the labs that the trauma team likes. They can order all the CAT scans that the trauma team wants. So that's a separate protocol that we use in our traumas. But it makes it so much easier because then the trauma team isn't yelling out every single order, you know, that they want. And then we have an actual nurse, that's their only job in a trauma, is to sit and put in the orders there. Same thing with our stroke patients. With stroke, the stroke-like symptoms, they have to have a CAT scan within 10 minutes, according to the supervising bodies. And so we need to be able to get those ordered very quickly. We also check things like a blood sugar, EKG, other sources of, you know, where you could be having stroke-like symptoms or things that you need to know, but that the nurse can get going. Usually, they'll call the doctor and say, this person has facial droop, I think they have a stroke, I'm putting in the stroke protocols. But if the doctors are busy, they can get it going without even asking. Some are just plain laboratory tests, and again, these are not very complicated tests. These are very simple tests that are on here. We're not ordering, do you have D-dimer here? We're not ordering a D-dimer. This is not the place to order a D-dimer. You know, a test where you have to really know what you're doing. We're ordering the basics, the CBC, a BMP, a troponin, pregnancy test, a urinalysis. These are basic tests that we're getting. For example, our chest pain protocol is only EKG, CBC, BMP, troponin, and the nurse can place an IV. That's it. We used to have chest x-ray on there, but our radiology department, they will go get patients from the waiting room and take them to radiology. I don't really like that idea for my sick chest pain patients or my old chest pain patients. And so we actually just removed chest x-ray, and I can decide, are they well enough to go to radiology and get a 2-view chest x-ray, or are they sick enough that I just get my 1-view? So that was an example of, we looked at what was working or what more of the physicians liked or didn't like, and we changed the protocol and adjusted it to what made sense for us. Medications, like I mentioned, so some places are very focused on pain-free emergency departments, especially for children. So where I trained in Milwaukee, nurses had protocol orders for Tylenol, ibuprofen, intranasal fentanyl, intranasal midazolam, some places intranasal ketamine. So no IV, no pain. It won't be a protocol for us, but we are going to start using nitrous oxide for children, for IV starts or other painful procedures too. We'll be starting that in a couple months here. Other things, so many physicians may have an issue with giving like opiate medicines, right, to people. You don't want to give that for everybody with a sore throat. But it may be if they have a deformity, right, like a visible fracture, then maybe you could have a protocol for opiates. That one I think is the most controversial. Most people don't mind somebody getting a Zofran sublingual tablet while they're waiting, or getting an aspirin for their chest pain. And again, the nurses are trained on ask. Did they get one from the ambulance? Did they take aspirin at home? How much aspirin should they get? So that's part of that education process. Same thing with the x-rays, radiographs. So do you want to have a chest x-ray on there? Maybe an extremity x-ray. Does it sometimes make that you got an x-ray of the wrist, but you also need one of the elbow? Yes. Yes, that happens. But a lot of times if you've got the deformity, you can at least kind of narrow in and maybe get them back and get them more comfortable a little bit sooner by having the first x-ray done. CT of the head, we really reserve just for traumas or strokes, really. But you need to consider, what's the cost? Do you have radiology all the time? My smaller hospitals, the radiology tech lives at home, and they sometimes have to call them in, which is again why so many patients stop in my emergency department, because it's faster for them to just come to me than to call in a radiology tech, go get a CAT scan, and then transfer the patient. So those are some things to consider. Do you have the services available? What is the relative cost? To me, an X-ray, when I know Tylenol already costs $75, an X-ray doesn't really matter. They're going to get a big bill anyways by coming. I'm the most expensive form of medicine in the United States. Emergency medicine is the most expensive. So we do try to be cognizant of that, but again, when we're trying to also speed patients up and getting better care for them, we sometimes weigh those risks.
I just want to add a little bit, but I'll probably ask it to expand on it. We have like an emergency reviews on Wednesdays, each Wednesday of each month. One of the things that we've seen regularly is how do you balance costs versus, what do you mean it's complicated.
Everybody is trying to figure that out. Yeah, because we are the most expensive service. And some of it I think has to do with educating the public too, which I don't think we do necessarily a good job of in the United States. I see a lot of patients where if their parents grew up, just go to the ER for everything, don't make a clinic appointment, don't take Tylenol at home, don't, take care of yourself or anything, just go to the ER, then that's all they know. And that's where the patient relationship, I can feel kind of sad for them. I'm sorry that you didn't have a better resource than to come to the emergency department at 2 a.m. I can have compassion for them for that. Because I do think that's sad. A lot of times, new parents, right, they come in, they're like, what's this on the baby? I'm like, that's just like baby acne. This is simple. Don't you have a grandma to ask or an auntie to ask? But you can have compassion for them, right?
Here it's easier to have a grandma.
Yeah, a more.
Sometimes they advise more than.
Yeah, I was going to say, sometimes I have to say, one grandma says this and one grandma says this.
Yeah.
And then I say, you are the parent. You decide. You can decide this.
There's another question. What education do you provide to the patient's family? Or how do you handle complicated family or friends that are in the waiting?
I don't know that we have a long enough talk about that. So time to talk. No, I'm saying right now. I don't know if I can go on. How do I handle this? I think trying to find a common ground. It's just like dealing with anybody, right? Anybody that you don't know. You want to find a way that you're a common ground. I have to watch myself first. So if I find that I'm getting upset or angry or raising my voice, they're going to do the same. And so I have to keep myself calm first. Safety is also important, and safety of my staff, very important. So if somebody is violent, I have 24-hour security, right? And again, I have people on drugs, they're drunk, it's 2 a.m, I'm 5'2". So I need to know when to call my security in. Sometimes people respond well to like just settling down, talking calmer. I can give you a good podcast later. There's a good podcast that it talks about this a lot.
Yes,
Yeah.
please. No, because just expanding to what you were saying, one of the things we've spoken about is first how to empower, the physician that is in service, because many times they tell us, like when the specialists come, like they will instantly say, but if I am a GP, then you don't have that authority, you have that perceived authority, right?
Right.
Same or similar with nurses, right? And then the other is how to treat complex people. So
Yeah.
and just to expand it, I told you that we received some residents from Sanford,
Yes.
and they were very impressed how highly regarded physicians are here
Yeah.
versus in the States, which I understand now is complicated.
Well, there's a couple of reasons behind that. I think one is we have what's called nurse practitioner. Are you familiar with this? Okay. So nurse practitioner is a nurse who then does training. Politely, the training is not equal. Some programs are very good, some programs only online. Some places give you a set rotation, some people get to pick and choose. And what will people pick and choose? The easy things, maybe. I think that has caused a bit of a problem because they can actually get a training called Doctor of Nurse Practitioner and then try to say, I'm a doctor. And it's not the same. And I did 3 years or 4 years of undergrad, 4 years of medical school, 3 years of emergency training, and now I've been practicing for 10 years. You can't do that in an 18-month online course, right? You can't do that. Yeah, and then I think we practice paternalistic medicine. Does that make sense? Where I'm the doctor, what I say goes, there is no us back and forth. And all of our American culture right now is about educating yourself. So before anybody comes to my ER, what do? They Google their symptoms. I have a brain tumor. I need to go to the emergency department, and I'm all worked up about this, right? So now we're living in a society where people do come with some education. And sometimes it can be very helpful, because if I figure out you're worried that you have a brain tumor or that your child has this bad, terrible thing that you read about on the internet, I can then address that concern. That maybe has nothing to do with, of course I know that they don't have a brain tumor, or I know this is very simple to me, but that's what they were concerned about, or what their family member told them to be worried about. Yeah. I could do a whole talk on that. What are the actual protocols that we have in Sioux Falls? We have one for abdominal pain, and that's very general. So it includes people with flank pain, even people with urinary symptoms, vomiting, blood in the stool. It's very general. Before, we used to have a protocol for blood in the stool, one for flank pain, one for belly pain, one for lower belly pain, one for upper. That's too complicated. We made it very simple. Anything from here to here, the same protocol, all the same tests. We do get a CMP in that, so to get the liver function in there. We have our chest pain, and that's again for adults 30 years and up only. And that includes shortness of breath or palpitations, right? The IV access one, for seizure, we have a protocol for just making sure you get a blood glucose, right? Check those easy things that we all forget about if somebody's seizing.
If it's not pregnant.
Yeah, and make sure they're not pregnant. I know, yeah. So these were our protocols and how many times we used them in 2022. So you can see far and away, chest pain and abdominal pain are our highest usage. And that's perfect for us because those are the groups that we can make the most impact. A belly pain workup, especially on a female, can take forever, right? If they just walk in and get into their room. And nobody can ever pee whenever they get back to the emergency room. They all pee in triage, so this is perfect. We collect the urine in triage and then we can go from there. Very few, we've only recently started having a pediatric stroke protocol. It actually just got approved last year. And so that's why it's only 0. Also, very rare. That one won't be used all the time, but when it does happen, we wanted to have it in place. Vaginal bleeding, trauma protocols, stroke protocols, our overdose or altered mental status one, that includes things like Tylenol level, a salicylate level, alcohol, drug screen, kind of those types of things. I would say the chest and the belly pains tend to wait in the waiting room longer as well, versus somebody who is comatose with it or, obviously drunk. We try to get them out of the waiting room, so that's a little bit why those aren't used as frequently.
I have a question. If you add all of those protocol usage, would that be the amount?
Of our visits? No. There's still it's still a smaller percentage. I would say, what do we think, 4,000?
That would be like.
So like 5,000. So this is still like 10%. Right?
Okay.
Yeah. 46,000 and yeah. So if you're thinking about using this in your location, where would you start? And I would say you don't need to come out with 25 protocols for 25 different complaints and have all different labs on all of those. That's going to set you up to fail. That's never going to work. It needs to be very simple. Maybe it is just checking a point of care glucose on everybody who's a diabetic. Maybe just the nurse can check a blood glucose. Maybe that's where you want to start. Maybe it's just getting an x-ray if somebody has a visible fracture, or maybe it's the chest pain. Maybe that's something, they want us to work on, is improving our chest pain times. And so that's the one we start with. Pick one, start with that, make it simple, and then you can always add on from there. But remember, all of this comes with education, reevaluation, maybe tweaking things, changing it, and then adding them on. The first one's going to be the hardest, and then after that, people will kind of know what to expect, and then you can grow that from there. We didn't overnight start with 12 different protocols, right? It started small, and then we've adjusted. You might want to consider whether you want to include adults and children, or just adults by themselves. Because again, children are a little bit more difficult. Oh, one I was going to say, like topical lidocaine on a cut, that's one I use on children a lot, right? They all come in with a little cut, you put topical lidocaine, by the time they come back to me, they're already numb, they're ready for their stitches. It's all set and ready to go. It makes it just go really smoothly, right? So as I said, I'd recommend picking one group of orders or one complaint, one problem to talk about. Start with that, get everybody on board, educate, and then slowly add more protocols as you have success with that first one. So in conclusion, emergency department protocols are supported by evidence. They can be beneficial to both clinicians. I'm not getting bothered by ordering Tylenol for everybody in the waiting room. I'm not being the nurses and feeling, I don't want to ask her if she has, if she can put in one more order for me, or I don't want to bug her right now, she seems really busy. And so this can make our relationship with nurses and physicians much more collegial and beneficial. So that's all I had. I have some references if anybody would like those, or I can share the slides. Or...
Yes, I can share the slides with the participants.
Yeah. How about any other questions?
I agree.
¿Puedes ir a la diapositiva anterior?
Sí. On the previous slide?
Okay. Nowadays, everything is based on evidence, and sometimes the patient is out of the box.
Yes.
So an experienced physician will say, okay, this is the evidence, but, and that we're trying to enhance that. The protocols are a big frame.
Yep.
By the experience of the physician, and I always say, evidence became because someone said, oh, put this to work, accumulated experience, and then it turned into evidence.
Yes.
So you never, that sixth sense of the physician or the trainers.
It can't replace the physician.
Right.
None of this can replace the physician, and that's not the idea. This is not, this is to maybe rule out the obvious things, right? And we always see patients that will confuse us, or it takes, again, in 10 years, I've maybe seen two patients with the same weird problem, right? And so it won't ever replace them. Or you may need to look at a patient and say, I think it's pancreatitis. Our order set doesn't have lipase on it. So yeah, I need to see the patient and add that on. But I already know I'm going to need all those other labs too, even if they have pancreatitis, or even if they have a different surgical problem, I'm still going to need all those labs. Our abdominal pain protocol doesn't have imaging on it. So I get to just, when I see the patient, I decide, do they need a CAT scan or an ultrasound? What's the best way? Yeah, exactly.
So one of the questions that Dr. Meg was actually really interested in, so that he's not here, he's
busy, yeah, of course.
And taking advantage that we have our SAT team here is maybe how the protocols can even impact transportation of patients, and how
does it work now? Do you report on a patient, and then do you have to call a physician to figure out how you take care of them? Okay.
We have our medical director, so we stay with the clinical patient all the time, call the doctor. We have protocols because it's really different working in the helicopter, so we everything is more common for us.
Yes.
it's most common for us because in the aviation, the protocols is all the time working.
Yep.
For, I don't know, take off.
Landing, yeah, you can't be on the phone the whole time.
So it's normal for us working with protocol for people for the chest pain or trauma.
Yeah. So I wrote, our protocols are somewhat complaint-based for my flight team. Some are complaint-based and some are system-based. For instance, all of my cardiac medications are in one protocol. So whether it's AFib or heart block or STEMI or whatever, all of those are all on the same page. So the nurse and medic just go to one page and they can find it. Also, it includes my pressors for the blood pressure or whatever. We have one protocol for pain, and that can be anything from the Tylenol to the fentanyl. Now, your medical control, do they have another job as well? Are they doing something else, or are they only waiting by the phone for you?
No, and the protocol, because sometimes we go to the rural area, and it's impossible.
You can't get a hold of them. Right.
So we know what kind of medication using
Yeah.
pain or some situation.
Yeah. So ours, we have medical control that can be contacted with a satellite phone as well. But with the amount of protocols, it's maybe more like once a day or every, not very often that they have to call back, and only if there's something different. A lot of times the small hospitals will say, they maybe don't even know what the patient has. They just have to get them out of there. Our flight team then comes. We trust our flight team. We know them. We work it with them. Then they call back and say, I don't think this is actually what's going on. Here's what I think. Is there anything else you want? Right? But my point there is medical control can't always be waiting and sitting on the phone either. So protocols can help you get care of the patient started right away. And then if you have problems or if they don't fit into the protocol, then you call medical control for backup.
Or sometimes we have initial report, we contact the medical and say, oh, we think this happened, and this is very, very good. So I think using this education, it's not possible to contact you in this end, this happen.
Yeah, I'd be happy to share our protocols. I think we only have 30 total. It's not very many. I don't have a long attention span, and I don't like a lot of extra. So I'm very simple. Our protocols are just very, I like them very simple like that. Yeah.
One question regarding medical education for the staff.
Yep.
One of the things we've seen in the last weeks is that everybody wants to provide medical education, right? And specifically, one of the biggest challenges is how do you order that?
How do we
Especially because there's so many limited time.
Yeah,
right?
yeah.
My position in the hospital is quite new, so we're trying to start figuring out a way to do it. And particularly, you said, like, in the case of emergency, now seeing that the pediatrics part, like the trauma departments of pediatrics, is that this, like, we have to do a lot of protocols and have to train the staff properly because, as they're going to show you around today, the level of emergencies we are receiving are growing and in complexity and in volume. So, like, I think we're starting to get to a cat or mouse game.
Yeah. How are we doing this? Yeah.
Exactly. So, could you point us in that direction of what you guys do?
Yeah. And so we mostly provide education to our nursing staff. The physicians usually come with a long thing, and we do still support physician, we call it autonomy, right? Like they still are the decision makers. It's their license that we're practicing under and everything. For our nursing staff, we put out written education every week. If something is new or different, or we have, we call it a safe culture, making sure that we talk, clearly and specifically to everybody. And then we do what are called validations, and those are mandatory training sessions. We hold them usually like a half-day session and a half-day session 2 times a year, I think, 2 or 3 times a year. I don't remember. It's for the nursing staff.
How long?
They're like 4 hours long, but they go through everything. So we're required to retrain on how to place a full catheter, how to get an EKG. It's all that simple stuff too that we're required to train on. In America, we have lots of regulations everywhere. So there's always more and more things. But so we make it where it's like a full day training thing. For, like I said, we're going to start nitrous oxide. So that nurses needed to be trained on and the physicians needed to be trained on. So we actually used a couple things. One is an online education course where you go through PowerPoint slides and answer questions. At home, we call those Sanford Learns, or the Sanford Learning Solutions, that you'd probably be able to ask about, but we have a number of those. That's everything from how do I check a guaiac, right? Like I have to do that every year, prove that I can read a guaiac or read an acid-base level. And then we did that online, but we're also going to have a hands-on session. Okay, here's the nitrous oxide tank. Here's how you turn it on. Here's how you hold the mask. Here's what you need to do, you know, if the patient isn't doing well. And we have hands-on education. So for sure, hands-on education when you're starting something new, and then either on a biannual basis. For my flight team, we do hands-on education twice a year. So they actually do an online protocol test, which has true, false, and multiple choice questions about the protocols. They are allowed to use their protocol book because that's real life. We have our protocol book on Google Docs, or they have a printed book. PDF, yeah. Or they have a printed book that they keep in their pockets. But so during the protocol test, they can reference the protocols. And then our flight team does some procedures. So they place chest tubes, they place IOs, pediatric chest tubes, and intubation. What else? Staples for scalp wounds. We have a lot of old people on blood thinners that fall and hit their head. So our flight team places staples too. So then they have to do that in front of me twice a year, and I grade them, and you know, we work on if they have a problem there. So they do that when they start, and then twice a year in person.
So in total, 8 hours per year at least?
At least. I mean, for emergency department nurses, you do so much. You are touching on every single specialty.
Okay.
I think it's funny, and I laugh about it, but a lot of people look down on emergency medicine, like they're just emergency doctors. But I have to know enough about every single specialty to get the patient to the right level of care. And it really is, it's really a specialty. So, and it's good for me with my low attention span. I like something different.
Can you send us documents you send weekly basis just to get?
Oh yeah, I can do that.
Yeah,
okay. Well, I can send you on WhatsApp or your email. Yeah, I can do that. But yeah, they put out a little. It's a little sheet that has a couple different. What's the safe learning phrase of the day? Maybe it's being clear with the numbers, or maybe it's repeating back. If I tell you I want the patient to get 50 micrograms of fentanyl, you would say 15, yeah, and I say no, 50, right? So maybe that's what we educate on that week is speaking clearly back and forth, and then they'll have maybe we missed something. Maybe we didn't check a blood sugar on somebody having a seizure, and when we checked it, it was 48. And then that's our education for the week. Make sure we're checking the blood sugar for seizures.
So